So welcome back. We're going to talk about part 2 of the brain. So we closed last time talking about opioids, and now I'm going to move into cannabis. So if you look on this slide from a cannabis standpoint, remember I talked about the outside part is the cortex. So on this outside, you see a lot of receptor activation in the cortex. So the cortex is that high level of function. So there are a lot of receptors out there that are occupied by cannabis. So a lot of my younger folks who are like, hey, nobody can tell I'm smoking anything, leave me alone. And family and friends are like, you look a little impaired, you look a little high. There's cortical involvement, a lot of receptors in there. We then go down to that midbrain where you see that prethalamic stripe, do the same thing over and over again, same stimulation with cannabis. Down here in the reward pathway, that purple structure, again, heavy concentration of marijuana receptors there. The hippocampal region where short-term to long-term memory conversion happens. Not a lot of 4.0 weed smokers out there, some, but in general, there's some impairment. Disturbing study that came out of Australia, New Zealand, looked at potential drops in IQ, people smoking cannabis under the age of 17, by age 35, a 12-point drop in IQ. The cannabis advocates really hated that study. It was re-looked at in one of our peer-reviewed journals called The Lancet. A well-done study, a little bit disturbing. You can see involvement at the base of that brain where you see there's the cerebellum. That's where balance and coordination take place. So if you think about cannabis, briefly, just kind of a brief history lesson on cannabis. So I'm kind of an old guy, so back in the late 60s, early 70s, if you looked at cannabis concentration of what the active ingredient is, the primary ingredient that people smoke marijuana for is for THC, or tetrahydrocannabinol. So marijuana back in the 60s and 70s typically was around 1%, 1.5% THC by weight. So if you think simply if I bought 100 grams of marijuana, only 1.5 grams of that was actually the active chemical that gave me the euphoria or made me a little bit high. So cannabis now, if we look at 2020 data, basically what they would call pretty good marijuana is commonly 15, 18% THC by weight. You can buy really high quality marijuana that may be 30% THC by weight. If you look at what we call the concentrates, something has the acronym or street name of wax or dab or hash oil. You can buy that off the internet out of some of these states, Colorado or wherever. That may be 90% THC by weight. So there was a disturbing YouTube video, pretty long time ago, 7 or 8 years ago, showed these 2 young men giving their 3-year-old and 4-year-old nephews a blunt to smoke. So a cigar, open that, take out the tobacco, fill it with cannabis. And these, a 3-year-old and 4-year-old, they videoed themselves handing drug to the child. They both went to prison. But these little boys took inhalations off that and they became ataxic. They couldn't walk. They started falling, and that's because of this cerebellar involvement. So in my 15, 18-year-olds, you don't see them stumbling and falling, and that's because our body builds a tolerance to that very rapidly. But now, when people first smoke some of this high-grade cannabis, 18, 30% or more, then commonly there's a little spin, a little, ooh, that was quote-unquote, strong or whatever, and that's from cerebellar involvement. So if you think about that person that smoked a joint in 1969, 1970, 1 blunt is equal to 3 joints. So even if you're talking about 18% THC, then 1 blunt would be equal to, doing the math in my head, 54 joints smoked at the same time. If you're smoking 30% THC, 1 blunt would be the equivalent of smoking 90 joints from 1969, 1970 at the same time, right? I mean, it's a significant and very different drug than it was. So cerebellar involvement, but then again, we get back here to the reward pathway, and that's where we see the actual addiction take place. So in the reward pathway, what you can see is this THC receptor. So our brain is built with a THC receptor. When that data came out, the internet was blowing and going, and things just kind of exploded, especially on the West Coast. Look at old blogs and people going, oh my gosh, did you see the data? We're built for marijuana. We're built to smoke this. And the researchers were, like, probably not. And within 18 months, they identified the endocannabinoids. So in the opioid portion, I mentioned the beta endorphins. That was a beta endorphin receptor that opiates came in and hijacked. And basically that's what we have here. So we have, our brain makes a compound called the endocannabinoids. So this is actually an endocannabinoid receptor, but it gets hijacked by marijuana. And so from THC, when I smoke cannabis, my endocannabinoids are some of the major drivers, for example, in normal food intake, throughout the whole animal kingdom, all the way down to invertebrates. But what happens is when I take in cannabis, it hijacks that endocannabinoid receptor, and then I get a major stimulation of those dopamine receptors. So if you remember back to last week, when I talked about the peak sort of activity, that normal peak is at 150%. So with cannabis, we get levels that are about 165%. So if I'm a big marijuana advocate looking at my cocaine or methamphetamine friend that has surges of dopamine up into the 300, 800, 1100%, and I'm at 165 or 168, I'm like, hey, I'm barely above that normal threshold of 150%. But the question is how long do you stay over that threshold? And so marijuana has such a long half-life. So most of my marijuana patients, they don't clear their drug screens until they're out to day 20, day 25. The longest reported positive drug screen for cannabis is 77 days after the last exposure. So again, if we go back to this imagery, in this picture, I've got 5 of these dopamine receptors that respond when that THC receptor is activated. It's called a neuromodulator, and it feels like I've got about 165 to 170% increase in dopamine on board. But because of the half-life of the drug, it's very protracted. So you get that same desensitization that I talked about with both opiates and stimulants. And in reality, what do you see in real life, right? What do you see the heavy cannabis users still have so much pleasure, so much joy in doing? Nothing except smoking weed, right? It used to be when you hit the three-pointer, you got the 30% surge in dopamine, you love to play basketball, you love to go fishing with your dad, you loved a family vacation, and now it's flat, it's boring, I don't want to do that. It's lame, it's boring, and so what happens is that they desensitize their dopamine receptor population. So if I can be smoking weed and playing disc golf, I can be smoking weed and listening to music, whatever, but if I'm not smoking, I can't feel life, right? And so, like I talked about in the other, I look at my heavy cannabis user and I go, hey, I like life better than you like life. I like a moonrise better than you like a moonrise. I like a pizza better than you like a pizza. I like a sunset better than you like a sunset, right? I get to feel everything. A young man a couple of years ago, I gave that example, and he looked at me and he said, hey, Dr. Boone, I bet you don't like a sunrise better than me smoking marijuana watching a sunrise. I'm like, probably I do, because what you're trying to feel with the desensitized dopaminergic pathway is what I get with every sunrise, with every sunset, right? So just like those other models, it takes time for restoration, but you'll restore this over time. Now, the problem is you may not start to fully restore this until those drug levels clear, so it takes a while before those cannabis levels are dropping out and you start to get restoration of those dopaminergic pathways. Now, we also have that same damage to the feedback loop, that ability to have normal impulse control and judgment that takes 90 to 120 days to get better. Now, when I'm talking about cannabis, it's such a hot topic. I actually want to segue off of this and talk about the disease model of addiction. So, before I started working at La Hacienda, again, well-trained internal medicine doc, busy practice, lots of patients, very poor understanding of what addiction is. And if I had a family member or my wife had come here, even as a doc, and she said, no, I don't have a choice, I have a disease, for me I would be kind of, I don't know, right? I mean, it seems like you're choosing to do this. I don't know that I get that, right? So let's just talk about that just for a minute. So very briefly, I want you to ponder, what is a disease? Just think about that. Just what is a disease? So not some fancy diagnosis, explanation, but just simplistically, for me, a disease is something that is not a normal part of the aging process. Something that we go, that's not normal. So I went through 20 years of practice telling people, hey, you got to quit drinking. Hey, you got to stop using cocaine. Hey, you have a heart valve infection. You're going to die if you use heroin again. I did that for 20 years, but I never had a person come to my office as an internal medicine doc who had bad diabetes and told them to stop having diabetes. I'm like, oh my goodness, you have diabetes and we need to get you started on medicines, right? Somebody that came into my office with a GI bleed, passing blood with every, I never looked at them and go, hey, stop doing that. That's dangerous. I'm like, oh, that's not normal. It's not normal to have blood when you go to the bathroom. We need to get you scoped. We need to evaluate that. That's not normal. Disease, right? So what happened was when we started looking at addiction, they saw this clustering. So you would see in family groups and different things. And so the question was sort of nature versus nurture, right? If everybody you're growing up around, if what you see demonstrated as your primary coping mechanism with your parents or your uncles, your aunts, your siblings, whatever, is that somebody drinks or takes pills, surely environment plays some role. So what happened was you would see people, though, that were bright, educated, bright, accomplished, and they would have catastrophic consequence from drug or alcohol. You would tell them, hey, your liver function tests are 10 times normal. If you drink, you are gonna die. And 3 weeks, 6 weeks later, they're drinking again. And so finally people started going, is it possible that there's something different, just like my diabetic? I don't have diabetes. I can eat pie or cake. My pants may not fit well, but I can eat pie or cake. I don't get ill. Compared to my diabetic, I don't have diabetes. Finally, they're like, is it possible that they're different? So they began to look at what's called retrospective adoption studies. So retrospective, these were not planned studies. They just went back into detailed adoption records, and they took children who had been voluntarily given up for adoption by the mother, where the mother of the child had no drug or alcohol use, but the father of the child struggled with drug and alcohol. So the baby did not have any exposure in utero. So while that baby was developing, exposed to heroin, alcohol, did that change something? No, none of that. They had paternal, the father genetics. The father struggled with drug or alcohol. The mother did not. The baby voluntarily given up in adoption. Worldwide, the incidence of addiction is about 15%. Substance use disorder in some fashion. 85% of the population doesn't have it. 85% of the population drink a beer, drink a glass of wine, take some Ambien when they travel, a little prescription for Klonopin, get some hydrocodone after a dental extraction. They took 4, it's set in the medicine cabinet for whatever. 85% of the population doesn't have it. About 15% of the population does. So if that child is then taken out of a home where potentially there's chaos or drug or alcohol use, adopted into a 2-parent home with no drug or alcohol abuse in the home. Those are the only study criteria. Track that kid until age 20 to age 25, depending on which studies you looked at. Studies done in all of the major continents. And what do you see? By age 20 to age 25, did that number drop from 15% to 8% or 4% because they didn't grow up around it? No. That number was 40%. 40% of those kids active. What does that? Genetics of addiction. So I have blue eyes, my wife has blue eyes, we have 6 kids that all have blue eyes. No choice, what we call simple recessive genetics. That's not what I'm talking about. So we've mapped the human genome. We've identified at least 43 different sites now that increase susceptibility to addiction. So some of my patients by age 17, 18, 19, their addiction is exploding, right? Other patients drink socially until age 50, age 60, age 67. And then all of a sudden, things sort of blossom and things develop. It's like diabetes. I can get diabetes when I'm 12 years old. I can get diabetes when I'm 30 years old. I can get diabetes when I'm 65 years old, right? It ends up being diabetes, sugar metabolism issue. The question is, some people develop very early genetic expression very early on, other people later in life. So when I talk about the disease of addiction, it actually is freeing to me. So when I have patients that have been trying to stop for such a long time, it would be like the diabetic trying to feel good, not identifying, oh my goodness, you have diabetes. I need to get you started on insulin. I need to train you what to do from a diet exercise standpoint. Could I tell my diabetic, hey, stop the diabetes thing? I mean, they would laugh at me, right? I mean, but when I talk about this, I'm not saying that just because that then becomes an excuse. No, I can't do anything about it. I'm an addict alcoholic. I'm not talking about that, because what we know is, and I know there's more than one way to skin a cat, but here, this 12-step recovery principles, if you live your life based on these principles, it's like diabetes. If you take your insulin, if you exercise, if you eat right, your sugars are going to stay controlled. So from an addiction standpoint, what I know is, if you change and follow your life by these principles, then now you can avoid substances. And so just like my diabetic, does choice play a role? Well, no, not choice to have diabetes or not, but you choose to take your insulin, you choose to exercise, you choose to eat right. So my patients, your family members, you folks that are watching this, you now, if you've been here, you've gone through this process, you go, oh my gosh, I can do this, and if you do this, I don't go there. I don't have to live this life. The disease model of addiction. So genetics, somewhere around 40 to 50% of the issue. When I do people's admissions very early on, I ask them about childhood trauma or abuse, sexual abuse, physical abuse, molestation, life-threatening diseases, death of a parent, major trauma. As a child, adolescent, developing brain, we're not built for that. One of the researchers in our field, this guy named Macaulay, did a lot of research around major trauma during childhood and adolescence. Those things can increase risk by up to 40%. About 20% are idiopathic, the fancy doctor word for we don't know why you have it, but you have it. Take the opposite of that, somebody that has a horrific family history of breast cancer with the BRCA gene, your grandmother, your aunt, your mom, 2 sisters, your chance of cancer off the chain, do a prophylactic mastectomy, versus somebody who goes, wait, nobody in my family's ever had breast cancer, you can still have breast cancer, right? So the idiopathic at this point in time, and I think we're gonna find more and more, just like we're identifying sort of in mapping the human genome and identifying different areas that increase susceptibility. But certainly as a biologic machine, it's more complicated than just a computer, but the disease model of addiction. So I like to talk about that, number one, just because it's so helpful and it's so freeing. So when people are like, no, I don't want that label, I'm like, no, it's not a label, it's how you get to feel good again. It's like me labeling the type 1 diabetic. I'm telling you what you have so that we can get you started on this process and you can get healthy again, right? So the disease model of addiction. So when I talk about cannabis, it's such a hot topic right now, and legal, and is it legal versus illegal? And for me, it's meaningless. Is alcohol an addictive drug? 100% yes. Is alcohol a legal drug? Yeah, it is in every state. We tried the prohibition, it didn't work very well, but can my alcoholic safely drink because alcohol is a legal drug? Well, everybody would go, heck no. Cannabis, right? And so what happens is there's a bunch of 85%ers that don't have addiction. They smoke a little marijuana in high school or college and like, I gotta get a job. And they quit, they walk away. They might do a drug screen. They walk away, they don't care. So my patients go, no, it's just not a problem. I'm like, sounds like a problem. Did you forget I did your admission? You can't pass a drug screen. You violated your probation twice. You're going to go to jail because you can't not smoke marijuana. That sounds like a problem to me. Because if it's not a problem, awesome. It's not a problem to stop. Stop. Oh, well, no. Well, oh, wait, is it a problem? Because if it's not a problem, it's not a problem to stop, right? I mean, something different. So is cannabis an addictive drug? In my animal model that we talked about during that first lecture, right? If I put cannabis in there, that mouse gets habituated. Absolutely. It works in the reward pathway. I have desensitization of my dopamine receptors, meets all of those criteria. So to me, those folks that argue that marijuana is not an addictive drug, quote unquote, it's just an uneducated argument. Is alcohol an addictive drug? Absolutely yes. I'm not talking about legal versus illegal. I'm just talking about truth and what that is, right? So cannabis, my patients at La Hacienda, genetics of addiction, risk of addiction, have that genetic cascade activated. They have now become active in their addiction. They have to buy into cross addiction, which includes avoiding cannabis. So I'm going to move into this next slide, which as a guy that likes to teach is a difficult slide. So hang with me. It's a busy slide, but there's value in this slide. So this is a schematic of the reward pathway. So ventral tegmental area, nucleus accumbens, this area where all of the classic drugs of addiction work. So on that bottom thing, we can see opiates, ethanol or alcohol, barbiturates. For older folks in the audience, that used to be yellow jackets or barbs, quaaludes. Now it's primarily a headache medicine called butalbital. Benzodiazepines, Valium, Xanax, Tranxene, Restoril, Klonopin, clonazepam. Unfortunately, the sleeping pills Ambien and Lunesta are benzodiazepine-like in structure and have activity in the reward pathway. Nicotine works in the reward pathway, cannabinoids, which is marijuana, and at the top you can see amphetamine, cocaine, opiates, cannabinoids. Phencyclidine is PCP or angel dust, ketamine, sort of a dangerous dissociative medication used primarily in the anesthesia world. But you can see that the common pathway is in the reward pathway, and all of this has to do with dopamine at the reward pathway. Now, alcohol works on this via an imbalance, and it's a little more complex, but via GABA and glutamate. But the end pathway is dopamine activity in the reward pathway. So when we talk about relapse, we're going to look at this and we're going to show kind of what goes on with this model. So I want to go back to my mouse model. So let's say that this mouse has been exposed to alcohol, water, and mouse food. Nothing else. He's never seen anything else in its life, right? And this mouse ends up hanging out this bar all the time, taking in intravenous alcohol. So then I'm going to adapt the study. And I start to turn the pump on and off. But every time I turn the pump on, I put on a little light bulb in the cage, and then the mouse learns lights on, bars open, that kind of Pavlovian response, right? So I turn that thing on and off, but every time I turn the light on, that mouse runs across the cage and hits the bar. Then I'm gonna change it up again. I'm gonna completely turn it off. So now I completely disconnect this. This mouse initially goes over, tries to get substances, and then the animal learns there's nothing there that I want. In one primate study, lever pull for cocaine, primate pulled that lever more than 1,000 times in a row, trying to get that cocaine administration. But eventually the animal goes, hey, there's nothing there I want. And simplistically, this mouse goes back to just normal mouse life in a box. Now I'm going to adapt the study further. So about 6 weeks go by. I then take the cage and I lay across the floor of the cage an electric grid that gives a mild painful shock to the foot pad of the mouse. So as the mouse explores the perimeter of the cage, there's nothing there the mouse wants, and there's adverse consequences if the mouse steps on that. So now the mouse has a new perimeter. Nothing there the mouse wants, pump disconnected, adverse consequences there. The mouse now lives here. 6 more weeks go by, which is a pretty long time in the life of a laboratory mouse. And now this mouse has seen alcohol, water, and mouse food, nothing else, right? Now I take needle and syringe into this IV catheter and I inject a microscopic dose of something else. Let's put a tiny dose of heroin, a tiny dose of methamphetamine, a tiny dose of cocaine. Something this mouse has never seen. This mouse has only seen alcohol, water, and mouse food. For almost 12 weeks, this mouse has not hit this pump. He lives here. I inject microscopic dose of a different drug. 14 seconds after the injection, that drug has gone into the venous system, into the brain of the mouse. The mouse whips around, stares at that thing, commonly takes one painful shock, runs across this thing, and starts to hit on that bar. What is that? It's cross addiction. It's what the AA community has talked about for decades, which is you have a favorite. You like something more than anything else. Alcohol is what you like. Cocaine is what you like. Methamphetamine is what you like. And we tell you, you need to avoid all of these compounds. Any compound that works in the reward pathway. So when this mouse, and I can flip this around any way I want to flip it. So let's make this mouse has only seen cocaine. And I give the mouse alcohol into the system. Any drug, any way I flip this around, this mouse whips around and runs over here, cross addiction. You have to buy into cross addiction. I've been here since November of 2004, 14,000 plus different patients, and I can tell you over and over from a relapse standpoint, patients that I take care of, well, no, I thought I'd be okay if I just drank this. I thought I'd be okay if I just took some pain pills. I thought I'd be okay if I just took some Xanax just when I got really anxious, and I see them back. Because what happens is when you chemically turn on the reward pathway, you elicit the craving phenomenon, you elicit the process. So some of my patients, it's very profound rapidly. So literally within minutes or hours after ingesting that chemical, yes, they experience that obsession, that craving, that desire. For other patients, they don't feel it, right? But it's kind of like if I keep leaning against the screen door, if I keep pushing on the screen, eventually I'm going to push that screen in. So sometimes my patients are like, hey, Dr. Boone, on your benzodiazepines, right, which also increase this, the benzo family, no, I can't function without my Klonopin, the benzodiazepine Klonopin. I can't function without it. And I remind them you weren't functioning with it when you came to La Hacienda, because by definition, nobody comes here because things are going well, right? But they're like, yeah, I know, I've never abused. I know, but you can't stay away from alcohol. No, Dr. Boone, the last 2 treatment centers I went to let me take it. I'm like, yeah, shouldn't a big bell be going off in your head that you're back in treatment? Because every night when you take your Klonopin, every day when you take your Klonopin, you continue to stimulate the reward pathway. You continue to chemically and artificially stimulate that until eventually either you're taking way more than prescribed or you've gone back or developed a new drug of choice. You have to understand, you have to buy into the cross-addiction data, right? And so my patients that argue with me about that, I'm like, you're not arguing from a place of strength, you're here. No, Dr. Boone, I'll be fine smoking weed. I'm like, you're not an 85%er. You're not one of those people that can drink a glass of wine. You're willing to risk everything, losing in probation, your drug screen, whatever that is. So cross-addiction, buy into the cross-addiction data, regardless of how I kind of go about that. Now, if you go back this slide, you can see another up here at the top, that HIPP for hippocampus. So the areas of my memory that communicate to my reward pathway. So at La Hacienda, we have this voluntary sort of spiritual awareness program called Seekers, and when we're not on a burn ban in the hill country, there's a big fire pit up at the top of the hill. It's beautiful up there. But so patients will go up there at 6:30 in the morning, and there's this time, and they build a fire, and they come back to my office maybe to make rounds right after they've gone to Seekers, and they smell like wood smoke. For me as a big outdoorsman, when I smell wood smoke, I love it, right? It just floods my brain with instant memories of Christmas and campfires and camping trips. I mean, wood smoke, it just thrills, right? I instantly smell that in my memories. It's a delightful memory, right? The smell of chocolate chip cookies, your wife's perfume, name a bunch of different things, right? So there is this connection with our memory pathways. And so that's where we talk about cue, like cue the actor, cue-based triggers. So with cue-based triggers, we basically think about three broad categories. And we think about people, places, and things. So let's go back to my mouse model. This mouse has been away from substances almost 12 weeks. This grid in the cage, I don't give him a cross-addictive compound, but I turn the light back on. And 6 weeks later, the light goes back on, and the mouse recognizes that cue, runs across this electric grid to stimulate that. So my patients, I'm like, hey, it's not going to work when you first leave here, especially that first 90 to 120 days. If you remember in the first lecture, I talked about those pathways that connect our prefrontal cortex. So those are the pathways that are damaged by substances. They take 90 to 120 days to recover. Especially during that first 90 to 120 days, these cue-based triggers are more potent. So I'm telling you, hey, if you're in the audience and you've got alcohol in your house right now, and they're coming back to your house, we maybe tell them not to come back. Early on, now look, you can't make them drink, you can't make them not drink. I get that. I can't encourage you enough, if you're a family member watching this, to go to an Al-Anon meeting. Can't encourage that enough. It's not, you can't fix them. If you could, we wouldn't be in operation. But at the same point, you can be supportive or enabling. So my, peanut allergy families that have children that almost die with anaphylactic shock with peanuts, once that kid gets into grade school and junior high, I don't know any of those peanut families that look at that child and go, hey, you can read now. We love peanuts. So we're going to have peanuts in this house from now on. Read the label. Stay away from it. They don't do that. It's peanuts. So I'm not telling you what to do or what not to do, but from a supportive enabling standpoint, you may want to think about that. And so early on, that first 90 to 120 days, it's a dangerous thing. No, it's a bad idea. Don't go back to the roommate that you've already paid the deposit on, but you just committed this last month of your life to sobriety to go live with the friend, the roommate, the boyfriend, the girlfriend that's actively using. It's a terrible plan. Places. If you've been at La Hacienda for 29 days or 31 days or 25 days, and now you're going to go back where you live alone, and for the past 3.5 years you've been drunk every night in that easy chair, and you've been here for 3 weeks, and you're going to go back alone where there's no structure, no accountability, have the same rough day at work, the same blow-up phone call, drive by the same liquor store, sit in the same chair, where your primary coping skill for the last 3 years has been alcohol and everything's going to be fine. It's a terrible plan. And again, I'm not telling people they can never be alone again, but that first 90 to 120 days is dangerous. You've got to guard that. You're going to go to the same bar and just sit at the bar and drink Sprite and eat a hamburger and throw darts with your friends and you'll be the designated driver. That's a terrible plan. That first 90 to 120 days, you have to guard against that. Things. I had a guy on the liver transplant list who had been a previous patient at La Hacienda who had severe end-stage alcoholic liver disease, and he had to go at that point in time almost 2 years to get his new liver. He came back to La Hacienda, dark yellow eyes, bright highlighter yellow, big swollen belly full of fluid, edematous. He looked so sick. He looked terrible. And I looked at him like, John, what happened? He goes, man, I had 20 months of, I thought I started drinking O'Doul's non-alcoholic beer. Looks like beer, tastes like beer, smells like beer. How long did his non-alcoholic beer experiment last? Less than 2 weeks before he's drinking. How long did that last? Less than 2 weeks before he came to La Hacienda. How long did that last? By day 4, he was getting sicker instead of better. I had to send him to the local hospital. Less than 48 hours after he got to Sid Peterson, they life-flighted him to San Antonio Methodist, where he died 2 days later of end-stage alcoholic liver disease, right? Guard against that. Be careful with those things. Guard against those processes. It's just a neurobiologic process. Now, family members, this is not to make you panic. The goal at La Hacienda, we make a really big deal about this. The goal is for our patients to be recovered. So recovered and cured are very different words. So we don't believe in the addiction cure, but we believe our patients can be recovered. So the difference between recovered and cured, I think the best analogy for that is physical fitness. Can a human be fit? Can you not be, you're not getting in shape, you are physically fit. Absolutely. So watch the Olympics, watch the NBA Finals, watch March Madness, these athletes that are working out like crazy on a regular basis, playing, those guys are fit. They're not getting in shape. Now, what happens if you win the gold medal, you retire, you sit on the couch, you eat donuts and watch ESPN for 6 months? What happens to your fitness? Your fitness goes away. You were fit, but that fitness was dependent on your diet and exercise pattern. What we talk about here, these 12-step principles, the most reassuring thing I can tell you is, since November of 2004, thousands and thousands of patients. So people say, so what's your success rate? I'm like, gosh, I can tell you a number, but it's so patient dependent. Let me flip it around and ask you a question. What's the success rate of diet and exercise? If you're overweight or out of shape, what's the success rate of diet and exercise? Well, it's actually 100% if you do it, right? Nobody's ever left Navy SEAL camp in bad shape, right? It depends on, and it doesn't matter what you feel like eating, what you feel like doing. The question is, what did you eat? What did you do? Diet and exercise. And the remarkable thing for me in working here now for years and watching this is that over and over again, what I see is that if you live your life based on those principles, you become recovered. So the reason I talk about that is that when you are recovered, so my patients that have completed their step work, sponsoring other people, they're this emotional, spiritual fitness. When that person in that emotionally, spiritually fit place, when they are exposed to cue-based triggers, it's insignificant. Go to Chili's, drink a Diet Coke and eat a hamburger with your best friend who's drinking a beer. You're good. You're fine. You're healthy. Go to the pharmacy and pick up a prescription of opioid for your child's post-surgical pain. They're fine. They're in this place of neutrality. They're these healthy, recovered people. But you don't get that right away. That takes work, just like physical fitness. So if I go back to that example of physical fitness, so if I take somebody who literally weighs 600 pounds, and they work out with a personal trainer and a dietitian and a fitness expert, they may lose 100 pounds in that first 6 to 8 weeks. Phenomenal progress, amazing. They've lost 100 pounds and they've dropped from 600 to 500. They got a long way to go. They're doing great, but they got a long way to go. They're not well yet. When patients leave La Hacienda, most of them from a spiritual and emotional standpoint, they're kind of 400 pounders emotionally, spiritually. They're not recovered, but they're getting better. And the goal is when you get to that recovered place, then you're not at this, you don't live your life on eggshells like oh my gosh, what Dr. Boone talked about, cue-based triggers. I don't want to have that. And you have to have a surgery and you get opioid exposure. When you're physically fit, when you're recovered, you're good, you're okay, right? You're healthy. So I can go through and I can just reassure people the goal is to get to this recovered state. So when I talk about that, don't also have this high level of angst and or panic that they're always on eggshells. You're 14 seconds away from relapse. No. The goal is get to this recovered place, to be there, to recognize that, to respect that, and treat that disease with ultimate respect. I then look right below where it says HIPP. You can see this initial CRF. That stands for corticotropin releasing factor. That's one of the things that tells our brain to make more steroid, one of our stress hormone responses. So major stressors during childhood and adolescence that increase your risk. Later on, those stressors. So we use a large kind of mnemonic. I just use the mnemonic BHALT, B-H-A-L-T. So these are just an acronym. So B is boredom. It's funny that you think of that as a stressor, but your great-great-grandmother would say idle hands are a devil's workshop, right? This thing, if you, from a patient who first leaves La Hacienda, I need structure. I need accountability. I don't want to give you very much time off of work. It's what's so scary during this coronavirus pandemic when I have my patients who struggle with alcohol that have now lost their support system. They have downtime. They're stuck at home by themselves without support, without structure. Such a dangerous time, right? Boredom. So early on, a week off when you first get out to kind of get some emails and make some appointments and hopefully get with your sponsor. But early on, guard that, guard that. H, hunger. Take the mouse and just take the food bowl away from the mouse. Empty the food bowl. And a few hours later, this mouse runs across the grid and hits the bar. Again, for humans, right, it's not this recognition, but commonly where I see in that is somebody gains 8 pounds at La Hacienda eating desserts, and they go home and they're skipping meals trying to lose that 8 pounds, and all of a sudden in the afternoon they want to drink so bad, they want a pill so bad, and in reality I want to talk to them and go, hey, what did you have for breakfast? Coffee. What did you have for lunch? Celery. I'm like, go get a hamburger. Go get some food. It's just a hunger-mediated CRF trigger. A, anger. Take a stick and just irritate the mouse. Don't hurt him. Don't hurt him. The researcher just kind of follows the mouse around with a stick, and this mouse is kind of swiping at and biting at, and then all of a sudden the mouse ignores the researcher and runs across here and hits the bar. What's the chance that my La Hacienda patients struggle with anger a little bit more easily than most of us? Pretty high. Why is that? 2 different reasons. Part of sort of the genetic basis on addiction is that those people operate, they're a little bit, they're kind of like a fine-tuned sport car. They're a little things that restless, irritable discontent. They operate on a little higher level, so things might irritate them a little more easily just at baseline. But then what do they do? What's their primary coping skill? I drink, I take pills. I don't want to feel this. I can't handle this. I want to feel different in 10 minutes. I'm going to drink until I feel it in minutes. That pill, I'm going to crush it and snort it up my nose because I don't want to wait 45 minutes. I want to feel different now. Well, what family conflict, what major thing gets better in 5 minutes, in 7 minutes, in 13 minutes? And so they become even more sensitive. I'll make the analogy. I'm kind of an old guy and put 6 kids through college, and I work hard, and I wear shoes most of the time. I don't go barefoot very often, and now when I go barefoot, I walk outside, everything hurts my feet, right? I don't have any calluses on my feet. Hypersensitive feet, right? And so my kids make fun of me when I'm barefoot because the way I walk, and I'm like, this grass is sharp, right? And my kids are mocking me. But my patients, right, they don't have any calluses on their life, so things are hypersensitive. Like, I'm not gonna come here and be here and pay this kind of money and have a roommate. I'm like, yeah, you are. Because if that's a stressor, we're in trouble. Because life is stuff. Right? I got to learn how to deal with things, and that has everything to do with 12-step recovery and making amends and going through your 4th step and inventories and learning how to experience life again. How do I get calluses on my feet? I got to go barefoot. It's going to be uncomfortable, but what's going to happen over time is that I'm going to build that resilience, and things are going to change. And this is not, family members, this is not to make you the emotional hostage. Oh, you made me angry. It's your fault that No, that's not what I'm talking about. And patients, it's for them to be attuned to this, To be aware that when the big blow up happens, when the conflict happens, this is not the time to go for a little drive after the big conflict blow up with a family. That may be where you call your sponsor and go, oh my gosh, my husband, my wife is driving me crazy. What are you doing? Let me go get a cup, let me process this. Let me get a cup of coffee. Let's talk through this. And the next thing you know, things are better. Guard, be careful on that. L, loneliness. This crazy, amazing camaraderie that my patients in 12-step community get. I'm not in recovery. That's again not one of my struggles, but I tell you, I envy that. I've got great friends who are in this recovery program, watching their relationships. It's beautiful. I mean, but for family, if they start to shell up, they start to isolate, they start to kind of pull back in, dangerous, dangerous time. Again, CRF-mediated trigger, loneliness. Tiredness. Sleep deprivation. Sleep deprive the mouse runs across the grid and hits the bar. Sleep is a whole nother separate topic as we learn and talk about what we call sleep hygiene and training them about what that looks like from a sleep standpoint. So the classic kind of things that lead to relapse. There's other education that we won't have time today to talk about on some relapse prevention medications that can help, that your family members are going to be presented. But the bottom line in these two lectures is that I want you to recognize that it's something bigger. It's not just stop. It's not that simple thing. If it was that simple, they would quit. The problem is an internal problem. These stressors that I mentioned, they don't cause addiction, but they can activate that process. For me as an outdoorsman, a brand new axe handle, I can't break a brand new axe handle. I can stress that thing, I can't break it. But if it's got a crack in it, a flaw I can't see, and I stress that, the thing breaks and people go, all of a sudden, no, did I break the axe handle? No, it was flawed axe handle. Those stressors, those things they're not the primary problem. The primary problem is the substance use disorder. The primary problem is the alcoholism. The primary problem is the drug addiction. And yes, we want to address these things. Yes, you may need counseling. Yes, you may need other things as a part of this process. But I want you to just recognize that this is something bigger. And then I really want to leave you with a sense of hope. Relapse does not have to be the option. Our goal is the recovered life. The goal is that you live your life based on these principles, and I maintain that. Again, it's just like diet and exercise. I do that. And just like diet and exercise, it doesn't matter what I feel like doing or what I feel like eating. The question is, what did I do and what did I eat? Are they working with a sponsor? Are they working with other people? Are they doing service work? Are they involved in that deal? And again, that's the clinical aspect that you're going to learn about in this whole process with the family program. But from a medical standpoint, that data is just rock solid. So I'm so thankful for your time, and I know I've covered so much information in these last two lectures, and feel free to just kind of talk with your family members and contact us. There will be some information of other places that you can contact us for more questions. So thank you for your time. All right.